Dear moderators, ladies and gentlemen, good morning. It's an honor for me to be here with you sharing these informations. Dr. Didar has apologized for coming to the conference because of some personal issues, and he asked me to present him the paper on behalf of him. This is about the outcome of the first 17 PMMA keratoprosthesis surgery in Iraq. No financial disclosure in this study. The purposes for the Boston type 1 keratoprosthesis is becoming the procedure of choice after multiple failed penetrating keratoplasties or for severe neovascularization of the cornea. Here we reported the outcome of the first 17 Boston type 1 K-Pro performed in Iraq. It's about 17 eyes of 16 patients underwent Boston type 1 K-Pro with titanium back plate, either due to a previous multiple failed corneal transplantation or to severe neovascularization of the cornea, which is done by the author himself. The mean postoperative follow-up was 1 year. The preoperative best corrected was a light perception in 5 eyes, 8 eyes had hand motion, and 4 eyes have a finger counting on the face. The outcome measures were the best corrected visual acuity and post-operative complications. And when we looked at the results, we found that the post-operative best corrected visual acuity was ranging from 9 eyes, it was 20/200 or better. In 3 eyes, they have finger counting of 3 to 5 meters, and in 3 eyes, they have finger counting on the face. And there's no improvement in visual acuity for those who had a light perception initial visual acuity because of the optic atrophy. We would like to show you the video of the presentation.
Video?
نعم. This is a short edited video about the K prosthesis. Done by Dr. Didar Anwar from Niga Eye Hospital. It looks like some sort of mechanical surgery more than an eye surgery. The preparation of the graft takes a time. Just like this. We look in this table, we can see the preoperative and the postoperative visual acuity as we said in 5 patient preoperative they have a light perception of 8 hand motion and 4 counting finger at the face. In postoperatively they increase it to 9 patients with 20/200 or more and 3 counting finger from 3 to 5 meter and 3 counting finger on the face. About the complications, 3 eyes had showed or developed melting, and 3 eyes retroprosthetic membrane, and 6 eyes complicated with the glaucoma. 2 eyes that had developed melt successfully treated by replacing the bandage contact lens, but one melt have been treated by annular patching graft over the melt area. 1 eye with retroprosthetic membrane was successfully treated with Nd:YAG laser, and 2 eyes were not visually significant by the patient who are on any treatment, and the most common complication is progression of glaucoma, which necessitated treatment, Ahmad valve. Again, the table showing the incidence of the complication. The most common one was the glaucoma, but endophthalmitis, none of them. So in conclusion, Boston type 1 K-Pro could be a viable option after multiple failed penetrating keratoplasties. And the most common complication was the glaucoma. Thank you very much.
Thank you, Dr. Ahmed. Next is the lecture of Dr. Ahmed. Dual flap technique in pterygium surgery.
It's an honor for me to present this paper and share it with you. It's about the dual flap technique, pterygium surgery, and it's in form of a case series. We do have any conflict of interest in this study. We all know that the pterygium is a fibrovascular growth starting from the medial conjunctival sides and growing toward the cornea, causing destruction to the bone layer and centrangular in shape. And the exact etiology is still not known why it's happening, but the most authors agree to the risk factor of the chronic sunlight exposure is the mainstay of the risk factor. It has a variety of clinical manifestation, and the majority of the patient complains from the discomfort or disagreement on the ocular surface and the redness itself. Till now, the mainstay of the treatment is the surgical option, and in the past few decades, a lot of surgical options have been developed, but we face from now and then recurrences of pterygium and doing the surgery again over and over, and in the literature, up to 92% of the recurrences have been reported. For this reason, we would like to demonstrate and prove the new technique and its low recurrence rate. This is a hospital-based interventional case series with random sampling. It's carried in Erbil Teaching Hospital, Department of Ophthalmology, and the time of duration is 8 months. 40 patients have been enrolled in this study. Any patient with non-nasal pterygium, history of trauma, history of diabetes mellitus, corneal disease have been exempt out of the study. After the patient had been informed about the course of the treatment, course of the follow-up, a written informed consent obtained from all of them. This is a sketchy representation of how we did the surgery. After topic anesthesia, application to the patient eye speculum, then after injection of the bulk of the mass with the xylocaine, separating the xylocaine, separated the bulk from the base and removed from the ocular surface, then started to form the flaps from upper and down, separating it from the underlying subtenon and cutting at the edge of the cornea. And we paid attention to be as much close to the cornea as possible to involve the stem cells with it, and extending the incision to the upper and lower fornices in peritoneum. Then after the flap is readily movable and fused in the center and sutured by 2 sutures of 0.7 Vicryl. These are pictures of the surgeries showing the steps of the surgeries. Again, the injection of xylocaine, separating the bulk of the mass pterygium from the base, removing it from the ocular surfaces. About the ocular movement, removing from the ocular surfaces, we either used a blade to remove it from the cornea, or sometimes we also use it to delaminate the membranes in layer by layer. All the surgeries done by me and my colleague, Dr. Jala Azad. After removal, started to doing the flap in lower fornixes, extending to the lower fornixing, freeing the flap. Then the same thing for the upper flap, separating from the subtenon and cutting through the limbal area as much close to the cornea. After we formed the flaps, we sutured at the center and fused it together at the midline by 2 sutures. So, as it's shown here, the initial limbal portion of the graft of the flap, which was initially here, now it's changed to the center line. It helped us to prevent further growth of the pterygium. A total of 40 eyes have been enrolled in this surgery. 40% were male and 60% were female. Majority of them were unemployed people. Majority were the first time doing the surgery, but it's not shown here. At 12.5% of the surgeries, they had a previous pterygium surgery with a recurrence in other places, and we don't know what kind of surgery, but we involved in this study. The mean vertical diameter of the pterygium was 3.43 millimeter, and the cornea involvement, the mean was 2.41 millimeter. We followed up all the patients. The first day we checked for the presence of infection and checked for the slip and ligature, which might necessitate to do resuturing of the flap. At the 3rd week, we start to remove the corneal, the conjunctival suture from all the patients, and also check for the presence of granulation tissue. And at the end of the 3rd month, a careful slit lamp examination to rule out the presence or the absence of the recurrence. Out of 40 eyes, only 2 of them showed formation of granulation tissue, and it's happened at the 3rd week, and both of them treated successfully by removing of the suture and increasing the dose of the steroid. A 5 patient, which stands for the 12.5%, had a previous pterygium surgery. none of them showed recurrence by this technique. A total of 3 recurrences, which stands for 7.5%, were found to be having the recurrence of pterygium by the end of the 3 months, and all of them were within the major size of pterygium size and living in urban areas. So the explanation of this success and low recurrence rate is due to the involvement of stem cell polarity of limbal stem cell. And we do the comparing this study with other studies, and found it's much superior to the bare sclera, which it has high recurrence rate up to 80%, which is unacceptable. While the use of intraoperative mitomycin C, the literature showed low recurrence rate from 10 to 0.5% as much high as 38%. And we all know that the mitomycin C, even if it is very low or very rare incidence, it might cause a corneal melting. A dual flap recurrence rate is within the range of conjunctival autograft, from ranging 2% to as high as 39%. Again, the conjunctival flap show a low recurrence rate, a good result, but in some people it might give unacceptable appearances. The amniotic membrane implantation after pterygium surgery might be high, ranging from 12 to 48% more than this study. So overall, the advantage of this technique is that it's a very easy and fast method. It just takes about 10 minutes. We keep the limbal stem cell polarity and protect us against further development of the pterygium, and does not need any mitomycin C. Like other studies, we do have a limitation in the study. It's a short period of follow-up time of 3 months, but when we dig the literature, we found that it is a big study comparing all the other 4 studies, and showed that the majority of the recurrences occurred in a mean time of 4 months. So in conclusion, dual flap technique is a very fast and safe technique. It has a very low recurrence rate. Thanks for listening, and hope you enjoyed.
Thank you, Dr. Ahmed. Next speaker, Dr. Nadia, DALK simplified, basic for general ophthalmologists.